Hello, my name is Michelle Madero. I talk about hepatocellular carcinoma. Definition. Hepatocellular carcinoma is the most common type of primary liver cancer. It most commonly develops in people with chronic liver disease, such as cirrhosis caused by hepatitis B or C. Risk factors. The risk of hepatocellular carcinoma, the most common type of liver cancer, is higher in people with longer-term liver disease. It is also greater if the liver is scarred from a hepatitis B or C infection. Hepatocellular carcinoma is more common in people who drink large amounts of alcohol and have a buildup of fat in the liver. Cabozantinib versus everolimus. Cabozantinib Cabometyx is used to treat advanced renal cell carcinoma. It is also used to treat hepatocellular carcinoma in people who were previous treatment with sorafenib. Cabozantinib belongs to a class of medication known as kinase inhibitor. It works by blocking the action of an abnormal protein that signals cancer cells to multiply. This helps slow or stop the spread of cancer cells. Everolimus. Everolimus can be used to treat kidney cancer that has spread and advances pancreatic neuroendocrine cancer. It can also be used with a drug called the hormonal examines to treat some women with breast cancer that has spread. Application in odontology. Manifestation in the oral cavity is the presence of halitosis, chronic periodontal disease, bleeding due to change in coagulation factor, presence of candidiasis.
I had the opportunity to participate at the Ipsen Satellite Symposium in kidney cancer, together with my colleagues Dr. Bernard Scudier, Dr. Tom Pauls, and Dr. Tony Chueri. And my task at that Satellite Symposium was to translate the data that we have, the clinical report of the phase 3 trial, the Meteor trial with cabozantinib, and the Checkmate 025 trial with nivolumab, how we can translate that into selecting our treatment for patients in second line after failure to one prior tyrosine kinase inhibitors. At that moment, we presented 3 different clinical cases, and in this clinical case, we show different profiles of patients who were candidates to one or the other alternatives. Unfortunately, in this field, we don't have a biomarker, a predictive molecular biomarker that really can help us in the daily clinical practice. So we need to base our treatment decisions in things in factors like patient characteristics, age, comorbidity, co-medications, or in tumor characteristics, how bulky is the tumor, what is the tumor burden, how fast the tumor is progressing, and of course, the tolerability and the clinical outcome to the first line the patient receives. So I really hope the attendees, well, at least they thought twice about what they are doing in their practice.
Pros and cons. Treatment. The development of therapeutic options for the management of hepatocellular carcinoma is a great challenge that requires the approach of a multidisciplinary team made of medical oncology, hepatology, liver surgery, transplant, and radiology. Therapeutic approach is conventionally classified as curative and palliative. This treatment includes radical surgery, its resection or transplantation, locoregional therapy, including radiofrequency ablation y percutaneous alcohol injection, intraarterial chemoembolization, combination therapy and systemic therapy. Hepatocellular carcinoma. Pros. Surgical resection has been considered the most effective treatment and the only one that offered possibilities of cure, which is why it has been the first therapeutic option to consider in patients with liver cirrhosis C. Cons. Not everyone is a candidate for an operation and runs the risk of maintaining good treatment. Cabozantinib. Pros. Cabozantinib is a small molecule that inhibits multiple tyrosine kinase reception involved in tumor growth and angiogenesis, pathologic bone remodeling, drug resistance, and metastatic progression of cancer. Cons. Constipation, nausea, vomiting, change in ability to taste food, redness, swelling, canker sore, sore mouth, loss of appetite, y weight loss.
The treatment of renal cell carcinoma has changed considerably in the past several years. When we think back to the initiation of therapy, we had TKI therapy as the mainstay with sunitinib, pazopanib, and after that there were several other TKIs you could use afterwards. But really the sequencing was unclear and pro-inhibition TKI. Then we had the pivotal METEOR trial and CheckMate 2.5 done at the same time, showing that both cabozantinib and nivolumab offered us improvement in overall survival in the second-line setting. And so that led to a pattern of care where patients would start with a TKI, go on to receive cabozantinib, and then nivolumab, or vice versa. They would go on TKI, nivolumab, and then cabozantinib. And now, as we look at things evolving, the role of immunotherapy has really moved to the front line with nivolumab, ipilimumab approved in the United States, front line for those with intermediate poor risk disease. And we've just heard data on the combination of axitinib and everolimus showing marked improvement in response rates, PFS, with a press release for pembrolizumab showing improvement in overall survival in the frontline setting compared to sunitinib. So clearly immunotherapy is moving into the front line. And so one of the dilemmas we face is with cabozantinib being studied in VEGF refractory, does prior immunotherapy really, does it affect the activity of cabozantinib? And so that's unlikely to be studied prospectively. We did a retrospective review between ourselves and Emory of 86 patients who had received immunotherapy as the most recent line of therapy and then went on to receive cabozantinib. And what we showed overall is that the activity of cabozantinib was preserved. So by investigator-assessed response, 36% of patients achieved a partial response, with 79% deriving clinical benefit, either stable disease or partial response, with a median time to treatment failure of over 6 months. So I think there's a lot of subgroup analysis that we've discussed in detail on our poster. I think the main takeaway is that in the setting of prior immunotherapy, cabozantinib continues to have an important role, and will continue to have a role in the second-line therapy for our patients with metastatic renal cell carcinoma, and just gives us another definitive option for our patients in that situation.
Everolimus. Pros. Everolimus is a treatment that interferes with the functioning of a protein called the enzyme kinase, causes cells to divide and grow, and is often too active in cancer cells. Cons. Diarrhea, constipation, change in ability to taste food, weight loss, dry mouth, weakness, headache, difficulty sleeping or staying asleep.
The PRECOG 0102 clinical trial was evaluating the use of fulvestrant in combination with everolimus, an mTOR inhibitor, versus fulvestrant alone. And in this clinical trial, patients with AI-resistant metastatic hormone receptor positive breast cancer were enrolled. And what this showed was that actually the combination of fulvestrant and everolimus significantly improved median progression-free survival. It basically doubled it. The objective response rate itself wasn't significantly improved, but the clinical benefit rate was higher with everolimus. There were no new safety signals highlighted in this clinical trial. I really like the design of this clinical trial because I feel like in my patients whose disease is resistant to an AI, I'd rather switch them to fulvestrant. And it shows that the combination of fulvestrant and everolimus is really quite good. And this is now going to be my recommendation for a patient who has had resistance to an AI, for example, first-line AI with a CDK4/6 inhibitor. What the trial doesn't address is how well this works in patients whose disease has progressed on a CDK4/6 inhibitor, because the study was designed and enrolled before CDK4/6 inhibitors were being used so routinely. In my own clinical practice, that's not holding me back from using this combination, and I've actually seen it be quite effective in a number of my own patients.
The Bolero 6 trial's main purpose or stated purpose was a post-regulatory commitment that was made to authorities by Novartis to interrogate the benefit of everolimus with a AI known as aromasin versus using everolimus by itself. And one of the issues that we wanted to look at was how much does exemestane add to the benefit observed by using everolimus in the hormone receptor positive, HER2 negative metastatic setting in women who have failed or progressed on prior lines of endocrine therapy. So that was the primary endpoint of the Bolero 6 study. They also had an additional arm of the study which compared the efficacy with capecitabine in that line as well. And so it enrolled a little over 300 patients, and they treated about 100 patients per arm for each of those three arms across an everolimus and exemestane combination, everolimus alone, and capecitabine. And they looked at progression-free survival, safety and toxicity, efficacy, and other readouts. It has to be clarified, though, that the trial was not designed and statistically powered to allow for a head-to-head comparison between the three different arms. So it was purely intended just to show the relative magnitude of improvement for the combination of everolimus and exemestane compared to everolimus alone. And in the trial, they were able to demonstrate that the hazard ratio for the combination of everolimus and exemestane was 0.74. So it resulted in approximately a 26% reduction in the hazard rate of progression for women that got the combination compared to those that got everolimus alone, suggesting that there is a role for continuing to suppress estrogen production in a woman who is getting everolimus, and that the benefit isn't solely with the everolimus alone. And so I believe that it did not necessarily change practice as it currently stands. However, it does provide us additional clarity and information around the relative contribution of each of the partners in the therapy and what benefit they bring to the table.
Hepatocellular carcinoma is a primary cancer of the liver. It's a cancer that develops primarily in patients who have liver cirrhosis. It's the third most common cancer in the world and one of the leading causes of cancer death. The reason it develops is because when patients become cirrhotic, their livers become nodular and inflamed, and tumors develop in these inflamed nodules. The major cause for hepatocellular carcinoma has been hepatitis C, which has been one of the leading causes of cirrhosis. But more recently, we're seeing increasing numbers of patients with hepatocellular carcinoma who have fatty liver disease and have fibrosis, not just cirrhosis. So any inflammation in the liver can cause these tumors to develop. For most patients with hepatocellular carcinoma that present to our center, we evaluate them for liver transplant if they come in in the setting of cirrhosis. The other option is surgical resection or cutting the tumor out. And for those patients who are not suitable for transplant for one reason or the other, they may be suitable for a resection. Not everybody is suitable for resection, and it depends how bad the liver disease is, clearly. And the third modality is treatment from the interventional radiologist with either wires that go into the tumor and burn them from the inside with chemotherapy, or burn them from the outside through wires that come into the liver from the outside. All of these can be combined to get the best results for the patient. The advantage we have at New York Presbyterian for treating such a challenging disease is that the surgeons here are capable of resecting and transplanting the livers. And we have experts in interventional radiology at treating these tumors. When you have a multidisciplinary team that's composed of surgeons who do research on the disease, who can cut the liver out or can transplant the liver, as well as hepatologists who are invested in researching the disease, and oncologists and radiologists, you get a better result for the patient overall. And the patient is directed towards the most appropriate care, rather than being filtered into what the center is an expert at. We're an expert at all three modalities of treatment rather than just the one.
Issue update in Ecuador. At Hospital de Sol Guayaquil, a total of 67 male patients with hepatocellular carcinoma were analyzed with an average 31, 86 years old. The 3% of patients original from YX, 40% laborers, and 20% only studied elementary school. The associated variables were cirrhosis status, 20% the infection due to hepatotropic virus, 32.8% and insulin resilience, 25% the most important risk factor combination being DNA, more obesity, 20% HBV, more cirrhosis, 19% the first being included from the no cirrhotic group. Conclusion. Hepatic resection and transplantation remains the concerted curative therapy for patients with hepatocellular carcinoma in patients with early-stage tumor and advanced liver disease. Transplantation is clearly the treatment of choice with 5 years survival rate of roughly 70. Liver transplantation, however, is limited by organs short and the inherent risks for transplantation and immunosuppression. Cabozantinib versus everolimus. Progression-free survival was longer with cabozantinib than with everolimus among patients with renal cell carcinoma that had progressed after targeted therapy.
I'm Bill Breaux, reporting from Southwest Florida. The United States Food and Drug Administration has approved a new treatment for patients living with advanced renal cell carcinoma.
Cabozantinib tablets for the treatment of patients with advanced renal cell carcinoma who have received prior anti-angiogenic therapy were approved and granted Fast Track and Breakthrough Therapy designations by the FDA. This is the first therapy to demonstrate in a phase 3 trial for patients with advanced renal cell carcinoma robust and clinically meaningful improvements in all 3 key efficacy parameters: overall survival, progression-free survival, and objective response rate. The brand name of this new FDA-approved therapeutic is Cabometyx.
Thank you.